Hello guys, I hope everyone is doing great. This is Dr. T from Clinical Medicine with Dr. T. So guys, today's episode of a patient that I saw. So I'm doing clinic this week, so I was at the clinic from Tuesday. Monday I was post-course, I didn't go to the clinic, so I started going there yesterday. And this is like a real patient, guys. Like I said, in this section I'm always gonna bring real patients. So this patient came in, she was carrying that maternity booklet. She's 25 years. She came in with a history that she has been coming to check her high blood pressure. She's 13 weeks pregnant, 5 days. 13 weeks, 5 days. So she has been coming to check her blood pressures. She was put on methyl dopa or aldomet 250 milligrams daily. Okay, I have no reason to get depressed because I'm just an intern. But then the reason why I was depressed with this is that when I tried to flip her card, I saw that when she came about 3 weeks ago or so, and she was at like 10 weeks and a couple of days at that time when the diagnosis of PIH was made. She was diagnosed as PIH and treated with methyl dopa 250 daily. So guys, I wasn't gonna be, because she came for review, I wasn't gonna be that doctor who sees this patient, check the blood pressure and say she must go and collect more medication, because there's a lot that is wrong with this. The first thing that is wrong with this patient does not have PIH. She was an obese patient. Let me put that as well. She looked obese, but I didn't do the BMI, but she just looked obese. So the first thing that is wrong with this is that I hope you guys have watched hypertensive disorders in pregnancy that I've done. I uploaded a video on that. So the first thing that is wrong here is that you cannot be PIH when you are less than 22 weeks. That's the first thing. Yes, her high blood pressures, I agree, they were high when she came, and even yesterday they were still high. But she could not have been a PIH at less than 22 weeks. We needed to find the cause. Why is she hypertensive? Because by definition, pregnancy-induced hypertension starts only after 22 weeks. And then now we can begin to talk about, is it gestational hypertension, is it preeclampsia, is it eclampsia, and all those things. So that's the first thing. Even this, aldomet is not a daily dose. I've not seen an aldomet being a daily dose. It's a TDS dose, or at least BD, but it's not a daily dose. So this has prompted me to come to you guys and come and talk about. So I did send this patient for bloods to check for secondary causes, and she needs to be managed. Actually, at this point, I wasn't exactly sure, as I was discussing with the senior doctors there, that at this point, this patient is not really a maternity patient. This should be an internal medicine patient that needs to be worked up by internal medicine, and then they find a diagnosis, and also talk to Obs and Gyne as well, and see, because at this point, like I'm saying, is not a PIH. So I don't think that, by definition, her high blood pressure has got nothing to do with her pregnancy. So it was not PIH. Okay. So let's talk about secondary causes of hypertension. So what are the secondary causes of hypertension? So as we know that hypertension can either be primary or it can be secondary. And primary hypertension, also known as essential hypertension, basically there's no cause for this. It's like epilepsy. You look for the cause, you don't find it, and then you say, okay, your seizures are due to epilepsy. And then we label a patient epileptic because there's no cause. As long as there's a cause for epilepsy, as long as there's a cause for seizures, then it's not epilepsy. It can be post-traumatic seizures. It can be like head injury. It can be seizures from even meningitis. It can be seizures from whatever. So with this one, it's when now you have not found a cause, especially if the patient is young. But older people, most of the times they have essential hypertension. That's why sometimes they're not even investigated. They're just put on treatment. Ne? But when it comes to the young, meaning this definition of young it varies from article to article. But most they say less than 30, some say less than 35. My patient was 25 years, guys. My patient was 25 years. She was very young. And so now, what are the causes, secondary causes? So when someone comes in with high blood pressure and they're not that old for them to think that they've got high blood pressure, like this patient, they should be investigated for secondary causes before they can be labeled as hypertension or as hypertensive. So, and another thing, when do you investigate a patient for secondary causes? Not a young patient now. A patient that is on, a lot of drugs, like 4 drugs, 5 drugs, and the high blood pressure is still not controlled, that patient should be investigated for secondary causes of hypertension, even if they have hypertensive, because you can have other things that can develop later on. Let's say a patient develops multiple myeloma, which causes hypercalcemia, and we know that hypercalcemia does cause hypertension. Or this patient now develops hypo or hyperthyroidism. Now they develop on top of the hypertension. So the minute you have a patient who's got, firstly, someone who has got increasing blood pressures, acutely increasing blood pressures, such that now it's difficult to control, or they need more drugs for their blood pressure to be controlled, or now they develop TOD, which is target organ damage, in a short space of time. Those patients should be investigated for a secondary cause of hypertension. And also, a young patient, no family history of hypertension. Even if a patient has got a family, personally, even if a young patient has got a family history of hypertension, I would still want to investigate that patient for secondary causes before I can say they've got essential hypertension. So we should be worried when we get to about 4 drugs, 5 drugs controlling high blood pressure. Yes, it could be a diet problem. The patient is not adhering to this low salt intake diet and all of those things, and being obese, not exercising, all those things. The blood pressure can start going up and all of that, and especially because of high salt intake. So what would we do? What are the bloods what do we need to investigate for a secondary cause of hypertension? Okay, so let's talk about biochemistry and imaging. So the bloods that we need to take here is a TSH. A TSH is going to tell us if a patient has got hyper or hypothyroidism, because both of them can cause hypertension, especially even hypothyroidism can still cause hypertension. But we know it in hyperthyroidism. But you do that because it's going to tell you whether it's hypo or hyper. So TSH, and then you do calcium levels. When you do calcium levels, we're trying to check if your patient's got hyperparathyroidism. Hyperparathyroidism. So when you've got hyperthyroidism, you develop hypercalcemia, and then hypercalcemia does cause hypertension because of the effects of calcium in the smooth muscle of the vessels. It causes some kind of vasoconstriction and increasing peripheral resistance. Remember our formula. Please guys, if you have not watched management of hypertension, I talk about all the drugs in that video. Go and check that. So because like I said in that video, that once you increase this, blood pressure increases. Once you increase cardiac output, blood pressure increases. So once you increase peripheral resistance, blood pressure increases. So if you increase vascular tone, calcium does that. It increases vascular tone, and then you develop, because of remember, calcium, influx of calcium into muscles, it causes them to contract. So it increases vascular tone. So in your patient, you will need to do CMP, or you can do CMP, or you can just do calcium levels alone. The next thing that you wanna, another blood test that you wanna check for, you wanna do your UNEs. UNEs. Why do you do UNEs? UNEs, you wanna check the creatinine of the patient. You wanna check the urea there. You wanna check the GFR there, because you wanna check if the patient has got a primary renal diseases. And we know that renal diseases, they do cause hypertension, because a kidney that is diseased, it becomes difficult for the kidney to perform osmoregulation. And if you are not excreting a lot of fluids, you increase blood volume, and blood volume, we know that it increases cardiac output, and then later on it increases BP. So that's the first reason you are doing a UNE. The second reason of doing a UNE is you want to see if this patient is hypertensive. Are they developing any have they developed any renal failure? Are they having any renal impairment? So those are the two reasons. That's the UNE. Another test that you want to do, you want to do your, obviously, okay, in terms of the imaging, you want to do because what you want to rule out here, you want to rule out renal artery stenosis, and also coarctation of the aorta. Coarctation of the aorta. So with this one, you can do a chest x-ray and see a widened mediastinum in some patient, plus or minus. But what the easy thing to do, you can send a patient here for, you can do a CT. You can do a CT for this patient, and then you can pick it up if they've got any of those. A CT angio. That would be the imaging that you would want to do. And also, one of the things that you want to check also, you want to do cortisol level. Cortisol levels. Remember, when you've got high cortisol, it increases BP and also increases blood sugar. It causes glucose intolerance. Glucose intolerance. So they develop high blood sugars. So these are the patients who have got your Cushing's disease or Cushing's syndrome. You can do cortisol levels. Cortisol levels can be serum or urinary. And also, there's a big story about cortisol level. When is the right time to take it? Apparently, in the morning, that's when your cortisol is the highest, unlike during the day. And also, these patients might be having features of high cortisol, like buffalo hump. They might have central obesity. They might have your striae that you get with high cortisol. They might have that Cushoid phases. So cortisol there. And then also you might want to also do, let's do urine here. You want to do your metnephrines here. Metnephrines. What are metnephrines? I'm sure you guys know that in the adrenal gland you have three parts there. You've got the medulla, you've got the zona glomerulosa, the zona fasciculata, the zona reticularis. Yeah, so the adrenal gland, I think it's the reticularis, if I'm not mistaken, but it secretes catecholamines. Just check that and make sure. Catecholamines. So catecholamines are your adrenaline and noradrenaline, or your epinephrine or no epinephrine. So those, as we know, that those are stress hormones. So when they are secreted, they increase heart rate, they increase blood pressure. So now, and these are your stress hormones. You need them in when you are stressed, like when you are fighting, running, scared, all those things. You don't need them when you are relaxed. But now there's a tumor that secretes these whether you are stressed or not, and it causes, so if these are chronically secreted, they will chronically cause an inverted pulse and heart rate, and that tumor is called pheochromocytoma. So metnephrines are the metabolites of these. So they're the breakdown products of catecholamines, and then you see them on the urine. So they're called metnephrines. So there you're checking pheochromocytoma. So if a patient has got this, you might want to check if they've got other, your MEN2, multiple endocrine neoplasm. You want to check other features of MEN2, which is another topic. Just check MEN2. There's MEN1, there's MEN2. Yeah. So you want to do urine there. They say that you can also do metnephrines in the serum, like check for the levels, but it's better that you do it in the urine. And this urine should be a 24-hour collection. 24 hours, which means you might have to admit a patient to investigate them for you to get that. And also they are, so these are the very basic things that we can do for the patients. And also you want to check the BMI of this patient. The BMI of this patient. The problem with the BMI is obesity. I don't know if you guys know, how does obesity cause hypertension? Obesity causes hypertension in the sense that when you are obese, we know your muscle to adipose ratio, you've got a lot of adipose tissue, and adipose tissue requires a lot of blood to remain metabolical. So it requires a lot from the heart. Unlike someone who's got muscles, who's fit, whatever that the heart gives the muscle, whatever blood is pumped to the muscle, a fit person will the muscle will be able to remain metabolically active, metabolize with that blood that the heart is delivering to the person who's muscular. But when you've got a lot of fat in the body, when you are obese, it takes a strain on the heart to be able to supply all those adipose cells with the blood. So it works over time. That's why you get a high pulse in them, and in the long time, that's why obesity is associated with a lot of cardiovascular problems. So you want to check the BMI there. Obviously, this is something that is correctable. I'm not sure if I'm missing something. So there are also drugs that are implicated in hypertension, like oral contraceptives, anabolic steroids, NSAIDs. I'm not exactly sure how NSAIDs can cause I'm not sure if they mess up the kidneys first, and then I'm not really sure. But they also mention NSAIDs. They also mention chemo drugs. Chemo drugs, most of them, okay, not most of them, but the ones that causes hypertension, they mess up the kidney. So that's how. Another big one that we are forgetting, guys, I think it goes with obesity as well. Obstructive